Our next speaker, who just spoke, is Dr. Kyle Orwig. Dr. Orwig is a professor of obstetrics, gynecology, and reproductive sciences at the University of Pittsburgh School of Medicine. He is also the founding director of the Fertility Preservation Program and the Center for Reproduction and Transplantation at McGee Women's Hospital at UPMC. Research in the Orwig Laboratory focuses on stem cells, germ lineage, development, fertility, and infertility. The Orwig Lab is ideally located in McGee Women's Research Institute and McGee Women's Hospital of the University of Pittsburgh, and is committed to translating lab bench discoveries to the clinic for the diagnosis, prevention, and treatment of infertility. Dr. Kyle Orwig.
Well, thank you, Pat, for the invitation to come here today. And as you heard from Pat's introduction and also from my naive questions, I'm not an expert in neuroblastoma. However, I interface with neuroblastoma patients quite a bit because one of the side effects of treatments for neuroblastoma is infertility, because those drugs that are used to treat the disease don't distinguish between a rapidly dividing cancer cell and any other rapidly dividing cell in your body, and so it has a variety of side effects that affect various systems in our body, and one of those is the systems in the ovaries and the testes that produce eggs and sperm, which are the things that are necessary to have a child in the future. So as I said, we know that medical treatments for cancer and also bone marrow transplantation can cause permanent infertility. And this is an important problem because cancer survivors report to us through epidemiological surveys that their fertility status after they become a survivor has an important impact on their quality of life. And so for that reason, many of our learned societies recommend that all patients be educated about the impact of their disease and their medical treatment on their future fertility, and also that we have options to protect or preserve fertility. And for adult patients, those options are standard of care and easily accessible, and they include freezing eggs or freezing sperm or freezing embryos, because we know that those cells can be thawed in the future and used to achieve a pregnancy using existing standard of care assisted reproductive technologies like in vitro fertilization. But unfortunately, those options are not available to prepubertal kids simply because they're not producing mature eggs or mature sperm yet. And we think that this is an important human health concern because the really good news is that with improved therapies, the 5-year survival rate for kids with cancer is now over 85%. I'm not sure exactly where neuroblastoma falls in that range, but as you heard in the last talk, therapies are continually improving, and I think it's reasonable to expect that survival rates will also continue to improve. Now, these kids may not be thinking about the families that they might want to have in the future, but maybe that's something that we as a medical and research and advocacy community can help them to think about and at least preserve the opportunity for those kids to make a decision when they become adult survivors and are thinking about starting their family. Well, my talk will touch both on people with testes and people with ovaries, or boys and girls, but our lab is known for our work on the male side, and so one of the things that I'll say about that is that one of the features of sperm production in the testes is that it's maintained by a population of stem cells in the testes called spermatogonial stem cells. So even though these boys aren't yet producing sperm, they do have these stem cells in their testes that are poised to begin producing sperm at the time of puberty, and if we preserve those stem cells before they undergo their treatment for neuroblastoma, then we could potentially use those stem cells to restore sperm production in the future. We do similar things for ovarian tissues. Egg production in ovaries is not a stem cell-based system, so the technologies that we think about using in the future are different. And maybe one other thing I'll mention, because I'm probably the lone reproductive biologist here in the room, is that there are differences in the consequences of treatments in people with ovaries and people with testes. In ovaries, if you have a treatment that destroys all the eggs, it also destroys the hormone production. So that means in the future it may be necessary to get hormone replacement therapy to help your child progress through puberty. In testes, sperm production and testosterone production are separable events, and so while the treatment might prevent the ability to produce sperm and have a child, testosterone production is not usually impacted, and so the boys will progress through puberty just fine. Well, anyway, because we know that those immature ovaries and testes have the potential to produce eggs and sperm in the future, there are centers all over the world, including ours, that are actively cryopreserving testicular tissue for boys and ovarian tissues for girls because we believe we'll be able to thaw those tissues in the future and produce eggs and sperm that have the potential to produce a child. Well, we established our fertility preservation program in Pittsburgh in 2010. It was during that year that we requested approval to begin freezing ovarian tissues and testicular tissues. Like you heard in the last talk, these are human clinical research trials, and so it's important that we gain permission and that our trials be assessed to determine that the benefits of doing the intervention outweigh the risk of the intervention. And at that time, we decided that it was reasonable to freeze ovarian and testicular tissues for young patients, for those patients who we deem to be at significant risk of infertility. And we'll talk in a little bit about how we determine whether a patient is at significant risk. Anyway, we started freezing tissues for the first patients in 2011, and since that time we've frozen testicular tissues for 959 boys and ovarian tissues for 540 girls. And that's almost up to date, except I know we just did 5 tissues yesterday, so. But we do a good job of keeping track of our numbers, so I'm always able to give up-to-date information on that. We're proud of the fact that our patients have traveled from all over the world to access experimental fertility preservation options that are available in Pittsburgh, but you can imagine that that need to travel can create a barrier in access to care because maybe families have a child who's too sick to travel, or the cost of travel might be prohibitive. So several years ago, we developed what we call a coordinated network of academic centers. That's represented by all of the circles on this map. And under this mechanism, it allows individual sites to perform the surgeries to collect ovarian or testicular tissues at the site where the patient is being treated for their primary disease. And then rather than the patient traveling to Pittsburgh, it's just their tissues that travel to Pittsburgh where we have the infrastructure and the expertise to process and to freeze those tissues. And in fact, Dr. Desai's center is one of the ones who sends us tissues for processing and freezing. So when patients come to see us to preserve their future fertility, the types of diagnoses that those patients have can be seen on this slide here. And I hope what you'll see right away is that the red pie wedge is the neuroblastoma pie wedge, and in fact, that's probably the largest single disease represented on this pie chart. The other larger pie wedges are groups of diseases, so as you know, this is a very common childhood cancer, and as I'll show you in a minute, treatments for neuroblastoma are among the most toxic out of any of the diseases that you'll see on this slide. So I told you that we have a experimental protocol to freeze tissue for kids that we deem to be at significant risk of infertility. So the question is, how do we determine significant risk? And the answer is that we have a little tool. We call it the cyclophosphamide equivalent dose, or CED calculator, which is what you see on the y-axis of this graph. And basically, to be eligible to do fertility preservation in our center under one of these experimental protocols, a kid has to be receiving a cyclophosphamide equivalent dose of 4 grams per meter squared, which I don't know if I'll be able to get my pointer to work. Maybe I cannot. But anyway, the lower dotted line is 4 grams per meter squared. Can we go back one, please? The lower dotted line is 4 grams per meter squared, and you can see, of course, that all of our dots are above the lower line. The line above that is something that we consider to be at high risk of infertility, and that means there's a very good chance that the child is going to be infertile as a result of the treatment. Well, this is all of the diagnoses represented on the pie chart, but if we focus just on your neuroblastoma patients and we gray out all the other ones, you'll see that far and away the neuroblastoma patients are getting the highest doses of chemotherapy. In fact, it's not just above high risk, it's way above high risk. There we go, now I have a pointer. The neuroblastoma patients are up here, and as you heard in the previous talk, the majority of them are prepubertal. So both very high dose and also prepubertal, which means that they can't freeze eggs and can't freeze sperm to preserve their future fertility. Well, when we receive tissues in Pittsburgh to freeze for future reproduction, we process them in a sterile biosafety cabinet. That is here. That's just to make sure that no germs contaminate the tissues. And if it's testicular tissues, we simply cut those tissues up into little pieces that are 2 to 5 millimeters across. If it's ovarian tissues, we peel the outer surface off of the ovary because that's where the immature eggs live that can be matured in the future. And we cut them into strips that measure 0.5 by 2 centimeters in size. And in either case, we use a computer-controlled program to carefully lower the temperature of the tissue until it is frozen. The reason why you have to be careful is because if you think about the ice cubes in your freezer, when you look at them, there'll be little ice fractures going through the ice cube, but ice fractures in the tissue are like little knife blades that would cut it up, and so we have to very carefully freeze the tissue so that ice crystals don't form, and it preserves the function of the tissue better in the future. And we're a research center, so one of the things that's extraordinarily important to us is that all of our patients donate a portion of their tissue to research. So 75% of the tissue is stored for the patient's future use. 25% of the tissue is donated to research so that we can understand the impact of the disease or the medical treatments on the tissue, and also so that we can use those tissues to develop next generation reproductive technologies that we hope will benefit those patients in the future. Well, to summarize what I've said, the standard of care way to preserve fertility in somebody with testes is to cryopreserve a semen sample with sperm, because we know that those samples can be thawed in the future and used to achieve a pregnancy using existing assisted reproductive technologies. But for most of the patients that we're here to talk about today, they're not able to preserve sperm, so they're not old enough. And I've told you about the option to cryopreserve pieces of testicular tissue, and we do that because there are a variety of techniques that are currently in the research pipeline that we would believe will be available in the future to mature those tissues and produce eggs or sperm. And so for the next few minutes, I'm going to talk about 2 technologies that I believe are mature and ready for the clinic for our patients who have cryopreserved their tissues. The first one is a cell-based therapy. It's called spermatogonial stem cell transplantation. Remember, I told you people with testes have stem cells in the testes that are responsible for sperm production. The other technology that we believe is mature and ready for the clinic is transplantation of intact pieces of testicular tissue. Those pieces still have stem cells in them, but the mechanism for them to make sperm will be a little bit different. And so for the next few slides here, I'm going to tell you why I believe that these technologies are mature and ready for the clinic for our patients who have preserved their tissues. And by the way, this was extraordinarily important to us because it doesn't make sense to expose a young kid to the risk of a surgical procedure to collect gonadal tissues unless we're absolutely going to commit ourselves to developing the next generation of technologies that will allow them to use them. Before I leave this slide, though, I will mention that one day it won't be necessary for us to think about fertility when you just got a terrible diagnosis and need to proceed to treatment, because one day it may be possible for us to collect a skin biopsy or actually any cell from a patient survivor and turn those cells into eggs or sperm. I bet that technology is 20 years from the clinic today, but it will change how we deal with the fertility question at the time of diagnosis in the future. Well, to begin asking the question of whether it would be possible to use stem cells that are in the testes to restore fertility, we established what we call a monkey model of cancer survivorship. This is work that was led by Brian Herman, who was a postdoctoral fellow in the lab. And just to give you an idea how long this is, Brian is now a full professor at the University of Texas in San Antonio. So Brian treated monkeys with chemotherapies that we knew would cause infertility. That includes therapies that are used to treat neuroblastoma, by the way. Before he did that, he took a biopsy from the testes of those monkeys, and he cryopreserved cells that were obtained from those biopsies. Then the animals were treated with chemotherapy, and every week after that, we collected a semen sample to determine whether that chemotherapy treatment actually had caused infertility. And the results are shown here. So this is a graph of sperm counts, where you can see that the animals that didn't receive any chemotherapy at all, shown in the green line, are producing lots of sperm. But all 3 doses of chemotherapy that we use caused sperm counts to go down to 0 or near to 0. That means they caused infertility. Now, the animals that got the lowest dose, shown in red, you can see that sperm counts eventually came back up, essentially into the normal range. And that'll be the case for about 70% of cancer survivors, that they may be infertile for a while, but eventually, as long as some stem cells survive, then sperm production will come back. That's why your oncologist should be educating cancer survivors that they should use contraception if they're not planning to start a family, because sometimes it takes many years for sperm production to come back, and a patient survivor who thought they were infertile may find out, in fact, that they became fertile again. Now, the animals that received the higher doses, shown in the blue and the yellow lines, you can see that their sperm counts went down to 0 and stayed to 0 out past a year. So we figure this represents that other 30% of cancer patients who will be made permanently infertile as a result of their treatment. And by the way, the neuroblastoma patients, for the most part, are in that 30% because your patients receive very high doses of chemotherapy that are almost certain to cause infertility. So the next question for Brian was, would it be possible to thaw out this tissue or cells that have been cryopreserved and transplant them back into the same monkey from which they were obtained in the first place? That's called an autologous transplantation, transplanting your own cells back into yourself. So the first question for Brian is, how do we get those things in there? So I have to teach a little bit here. You're looking at an ultrasound image of a testis. This is all the testis here. Sperm are produced in these little tubules called seminiferous tubules. You can't see them, but they're up here and down here. But every one of those tubules both begins and ends in that echo-dense white structure that's running from side to side in the middle of the testis. And that's the structure that we target when we want to transplant stem cells. This is not a surgical procedure. It's simply inserting a needle through the base of the scrotum until the tip of the needle emerges into that reedy testis space. The testis is a plumbed system, so if we get the needle into the plumbing, then we just infuse and it'll fill up all the plumbing, and you'll see that in a minute. Now, in order for us to see where the cells are going, we put some little microbubbles in there because microbubbles show up on ultrasound. So once we start injecting, first you'll see that the reedy testis fills from end to end, and as we let this play, you'll begin to see bubbles going up into the seminiferous tubules out of the reedy testis space, which tells us that our therapeutic cells went to the place where we needed them to go to engraft and regenerate sperm production. So here's an example of one of those monkeys. He was producing sperm prior to his chemotherapy, which you can see here. We treated him with a chemotherapy that we knew would cause infertility, and that caused his sperm counts to go down to 0. So at that time, we thawed out his testicular stem cells and transplanted them back into his testes, and you can see 30 weeks later, sperm production came back essentially into the normal range. And we know that those sperm, I won't show the data today, but we know that they are capable to fertilize because we sent the sperm off to our friends at the Oregon National Primate Research Center, who have a monkey IVF laboratory, and they fertilized monkey eggs, and that led to embryo development up to the stage when an embryo would typically be transplanted into the uterus. We did transplant embryos into the uterus at that time. This is over a decade ago now. We didn't succeed to establish a pregnancy, so that's still work that we have to do and is ongoing in the laboratory, just to demonstrate that we can produce a healthy baby who grows up through healthy childhood and into adulthood. Well, I've told you about our research in monkeys, but I'd like to convince you that this is a technique that we also can do in human patients, because here you're looking at the testes of 2 teenage boys, and I hope you can see, as I do, that the rete testis is easy to visualize here, just like it was in the monkey. And not only are we confident that we could target that structure in a human patient, we've already done so, initially in adult patients who were coming to the clinic because they were infertile. And we knew we were targeting it correctly because when we stuck the needle in that space and flushed and aspirated, we were able to aspirate sperm. So that told us we were in the correct spot. But also, we've also done this on the first patient in the world who had a stem cell transplant. We did this just last November. This is a patient who had an osteosarcoma of his femur. He came to us in 2011 when he was 12 years old to cryopreserve his testicular tissues. He was our third patient who froze testicular tissues. Now, this was an interesting patient, and maybe this is a teaching moment too, because he had already started chemotherapy before he came to us and asked to freeze testicular tissue. And when I say he, I really mean his mom and dad, his family. And so nobody knew at that time whether it's reasonable to freeze tissue for a patient who's already started on therapy, because maybe those treatments already would have damaged fertility. But remember that I told you each one of our patients donates a portion of their tissue to research. So the pictures that you see on the right-hand sides are our assessment of his tissues, and the green spots that you see in those tissues are those stem cells that have the potential to produce sperm. So even though he had already started on therapy, he was in the early stages of therapy. It had not destroyed his sperm-making potential, and we confirmed that with the test on the right-hand side. So he came back to us, as I said, just last year. He was a 24-year-old survivor of his disease, and asked if he could have his cells thawed out and transplanted back into his testis, which is what we did. And part of the reason that I showed you the monkey experiment is to sort of teach what you can expect to see when we show you the video in the human patient. Again, a needle is inserted. This is under just light sedation for an adult patient. It's an off-it visit. A needle is inserted through the base of the scrotum. It won't be as pretty as the monkey picture because, we had hundreds of tries to get the perfect monkey picture. But I don't know if I can get my pointer back. But anyway, you see the rete testis fill, and I hope you saw a couple of bubbles going up into the seminiferous tubules of the testis, which tell us that the cells went to the place that we expected them to go. And of course, we're following this patient, and hopefully one day we'll see sperm in his ejaculate. We don't expect to restore normal fertility so that he can have a child in the normal way, but if he produces any sperm at all, there are technologies that already exist in the clinic that will allow doctors to use those sperm and achieve a pregnancy, or help him achieve a pregnancy. All right, the other technology that I believe is mature and ready for the clinic is not a cell-based therapy, but actually where we take intact pieces of testicular tissue that we froze and just transplant it under the skin. The skin can be anywhere in the body, so I like the idea of transplanting under the skin of the scrotum because scrotum seems like a good place to make sperm. So this was, again, returning to our monkey model of cancer survivorship. It was work that was led by Adetunji Fayomi, who was a PhD student in the laboratory. He now works for the FDA. And Karen Peters, who was a research associate, and interesting, now she's a nurse on the cancer floor at our institution, so we still work with Karen, but we work with her from a different perspective. Again, animals were treated with chemotherapy. Before that, we took a biopsy of the testes of these animals, and after we determined that they were infertile with no sperm production, we transplanted those tissues back in their body. Now, you won't recognize this because I haven't taught you what testis histology looks like, but I did tell you that sperm production happens inside seminiferous tubules. So what you're looking at here are the cross sections through round tubules, and these red cells are the cells that have the potential to produce sperm. There aren't very many of them there yet because this is a young boy and they haven't started to produce spermatogenesis. But the reason I showed this picture to you is so you can appreciate how much different it looks after we do the transplantation. So the way the transplantation works is that we just take 4 little pieces of tissue. In this case, we took 4 little pieces of tissue, and we individually sutured them under a skin flap. This picture is a skin flap that's in the back, and we transplanted tissues into 6 sites on the back and 2 sites under the scrotal skin. And we transplanted both fresh tissues as well as frozen and thawed, but of course we're more interested in the frozen and thawed because the patients will have had their tissues frozen for many years before they come back to use them. Well, this experiment worked nicely. We started with an immature tissue. When we recovered that tissue months later, you can see those 4 little pieces of tissue have now grown into a large mass, and you can even see one of the little sutures with that black dot up in the upper right. And again, the reason I showed you what the tissue looked like before the experiment is because now it looks dramatically different. You don't have to know how spermatogenesis works necessarily, but I think you can certainly see the before picture and the after picture look different. And the important thing here is that the green marks, if I can get my thing to work, the green marks here in panel B are spermatids and sperm. These are things that are capable to fertilize an egg. And in fact, when we tear the tissue apart, we're able to release mature sperm. See if I can make this work. Release mature sperm that are indicated here. And in fact, from every graft that we recovered, we were able to retrieve between thousands and millions of sperm. Does anybody know how many sperm it takes to fertilize an egg? 1, that's right. So if you recover between thousands and millions of sperm, that's a lot of reproductive potential. So again, the question for us was, are those sperm functionally competent to fertilize an egg and establish a pregnancy? So again, we did that by sending the sperm out to our friends in Oregon. They were able to fertilize, and after they fertilized, they produced 2-cell embryos, then 4-cell embryos, and 8-cell, etc., all the way up to the lower right, which is what we call a hatching blastocyst. You can see the embryo pooping out of the shell that it's in. And this is the stage when an embryo typically would implant in the uterus, so that's exactly what we did. We transferred the embryos into the uteruses of surrogate females, and we did that in November of 2017. A month later, we were able to confirm that we had a pregnancy biochemically. A month after that, we did a fetal ultrasound, and it showed that the fetus was developing normally. And so at that time, we scheduled a full-term C-section, and the result was the birth of Grady. That stands for graft-derived baby. Turns out when you produce a monkey experimentally, you're obligated to name it too, which I didn't know till the morning of her birth, and they asked me for her name, and I hadn't even thought about it. And this is probably my greatest moment of inspiration because I knew immediately what her name was, and that's what it came to be. She was born on April 16th of 2018 by C-section. Important to say, the C-section wasn't required. It's just that monkeys tend to deliver in the middle of the night, and we wanted to make sure that Grady got delivered during the daytime when there was staff available to take care of mom and baby. And she's the first monkey baby who was born from autologously grafted, that means grafting your own tissue back into yourself, frozen and thawed prepubertal testicular tissue, which we figure represents the young cancer patients for whom we've been freezing tissues. Well, just to finish up here, Grady still lives in Oregon. It turns out, in addition to having to name her, I'm responsible for her for the rest of her life, which will be about 35 years. But the good thing about that is that we get to monitor her development, and so what we know is that she's developing normally, just like any other baby that was born in the usual way. And this is one of those observation periods where there's somebody outside the window with a clipboard monitoring how she interacts socially with other animals and how she performs physically. And I'm happy to report that Grady's developing normally just like any other monkey. And in fact, she is post-pubertal now. And so we're breeding her with another monkey we made called Crixus, made by a different technology. And hopefully we'll be able to produce grandparents from the sperm that were made from the originally frozen tissues. So, I forgot, I do have one more thing. I will talk about girls, but just for one slide. And really that's because the ways to use ovarian tissues are much further advanced than the ways to use testicular tissues. The first instances of transplanting ovarian tissues back in patients happened in 2004 and 2005 in Belgium and in Israel. And what I'm showing you here is a picture of one of those first women to have ovarian tissue transplanted back into her body. This is Stina Berkholt from Denmark. Interestingly, she was also a researcher in the lab that developed one of the labs that developed the technology to transplant tissues, so she was on sort of the front lines at the time. And she was in menopause already at the age of 27 because of the effects of the treatments for her Ewing sarcoma. So she came back and asked if she could have her frozen ovarian tissues transplanted back into her body, which they did, and she was able to have her first child. Now, this was early stages, so we didn't know much about how long a transplanted ovarian tissue could last. And so when she and her partner were ready to have a second child, they came in and they asked, can we have more tissue transplanted so that we can have another child? But, oh, and by the way, she used IVF to have the first child. Nobody knew you could get pregnant naturally by transplanted ovarian tissue, so she used IVF. She came back and asked if she could have more tissue transplanted to have a second child, but it turns out that she was already pregnant naturally from the first tissue that was transplanted. And now there's really over 200 live births, but 180 that can be documented in publication from transplanted ovarian tissues. We know those tissues last for a long time, returning hormone production for over 10 years. And for that reason, ovarian tissue freezing is no longer considered experimental because we know we have a technology to transplant those tissues and achieve live birth outcomes. Okay, so what have I told you? I've told you that we have therapies in the case of ovaries already in the clinic, in the case of testes just emerging into the clinic, where we can restore fertility for people who froze their tissues. Unfortunately, those technologies won't be appropriate for all patients. You can imagine a patient with testicular cancer or leukemia that may harbor malignant cells in their gonadal tissues, and the last thing we want to do is reintroduce a cancer into a patient's survivor. So I did a little research on this, and it turns out, although I wasn't aware of it, neuroblastoma does sometimes metastasize to the testes and the ovaries. It's rare. The highest incidence I could find was up to 3%, but I think overall it's probably less frequent than that. And the reason why I was asking Dr. Desai the question about do the pathologists routinely look for markers is because if we're going to put tissue from a neuroblastoma patient back in their body, we're going to want to test it and make sure that it doesn't have any markers of a metastasizing neuroblastoma in their testes before we do a transplant. But if we have concerns about it, there are a variety of methods that are in the research pipeline that we hope one day will allow us to mature those tissues outside the body so we won't have to put them back inside the patient's body. So with that, I'll finish up. I tried to acknowledge the people who did the work when I presented it, but really I've told you about over 20 years of research, and so I have so many collaborators, not only in our own institution, but all over the world. And none of this would be possible without financial contributions from a variety of sources. And I always finish my talk by acknowledging the patients because they both inspire what we do in the lab every day, but also in many cases they're donating their tissues to research so that we can develop technologies that we hope will be available for them in the future. So with that, I can finish up, and I'm happy to take any questions.
What universities or research is being done are counter to you for females?
I'm sorry, say that one more time.
What your focus is on males.
Yeah.
Who is leading the work in the field?
So we do a lot of work in that space too, but nobody knows about it because we're known for the male side. That's sort of the part that we championed. But I'd say the other places in the world that are champions for research on females, one is at Northwestern University, a team that was initially led by Teresa Woodruff, but she's now at Michigan State. She was going to be the president of Michigan State, but some things happened there that made that not a desirable position for her. But some of her trainees are still there at Northwestern. But the data that I showed you about transplanting ovarian tissues back into the bodies of patients, this is led largely by groups in Europe and Israel and Australia. Those are the pioneers in doing both freezing and transplantation.
My daughter was diagnosed when she was 24 years ago, before much of this work was being done. So she had been exposed, obviously, to the high levels of chemo.
Yeah.
And what was happening that we were running into is cost issues.
Yeah.
Have you examined how that might be covered by
Yeah.
insurance?
It's a problem, and it's not just a problem in the context of fertility preservation. Generally, people pay out of pocket for reproductive treatments, which of course creates a disparity in access to care because the people that can afford it, and you know what else that means in terms of research, that our research data are data that are coming from people that have the funds to pursue the reproductive therapy. So that's not only for regular reproduction, but of course for fertility preservation. There is progress being made. There are about 12 states in the country now that require coverage for fertility preservation, and some of those also have coverage for fertility treatments in the future. I told you that one of the things that, or that some of the leaders in the field are in Europe. Interesting, they have socialized medicine there, and so fertility treatments are generally covered by insurance, and that makes a great difference in access to care, and also it's one of the reasons why they were sort of first on to begin freezing tissue, because freezing the tissue could be covered and the future treatments could be covered. And final thing I'll say to that, so I'm hoping that more and more states come on board in the United States, but that's a tough road to hoe, I have to tell you. And even as states mandate it, private insurances won't have to follow those mandates. This will be for government insurances that it'll cover. Final thing I'll say, that at least in our place, for freezing of ovarian and testicular tissues, because they're experimental, we cover all those costs. This is both good and bad. It's good for our patients, but it's bad because some patients will make a decision to travel to Pittsburgh because the costs are covered, rather than to get treatment in the place where they're being treated for primary disease that might actually charge them for the surgical procedure.
At what point, obviously we were talking about the delays, and at what point should parents here be talking to you or others?
Oh, yeah, thank you for asking that. So, first thing, as soon as a diagnosis happens, I told you that we've frozen tissue for a patient who'd already started treatment. But ideally, we would be freezing tissue for patients before they've had any exposure at all, which means it's happening in a very compressed time frame between diagnosis and treatment. This is what our team is all about. This isn't easy to do. We know families are stressed out. They're dealing with a lot. They just got a terrible diagnosis. They need to get on with treatment. There's being lots of information dumped on them. And so that's what our team is dedicated to, is to make that as easy as possible, coordinate the surgical procedure as quickly as possible. And yet, we still understand that it's hard to hear from a family that's digesting a lot of information.
Because you're talking about weeks. The diagnosis happens, maybe treatment starts right away. Can you get involved that quick?
Yes. So, and by the way, so I told you that we freeze tissue for over 40 sites around the United States. So every site will be different. Some of them can do it and some of it can't. And even in our place, so the answer is yes, we've scheduled a surgery the next day.
Wow.
But we can't always do that. I mean, we have nurtured a relationship with our surgery schedulers that allows us to jump the line, but it took a long time to educate, to say our patients are special. You can't put them on a 3-month waiting list for a surgery.
Yes.
Our patients need to be treated right away, and this has been years' effort making sure that that's a dialogue and a mantra that happens in our place.
Final question. Most of the folks, our daughter got exposed to chemo before we even started to think about this. We froze the eggs, and we came down to a very emotional state because we were concerned about the quality of our damage. And do you have mechanisms in place that will give you a pretty good an accurate prediction of harm?
Yeah, the best way that I can answer that question is that people who are cancer survivors are not at a higher risk of having children with a higher incidence of cancer or any other disease. Now, there are exceptions. Of course, there are cancers that are genetic basis, so then you have a chance of passing the mutant gene onto the child. But if it's not a genetic cancer, the epidemiological data, and this is thousands and thousands of patients, indicate that cancer survivors that are not at a higher risk of having children that have cancer or any other disease. So that suggests it's safe.
I'm more concerned about the impact of the toxicity.
Well, if it's a cancer survivor, they've been exposed to the toxicity. That was my point. Okay. So, of course, and this is big picture, so it's every type of cancer, every type of treatment. Of course, individual cases could be different.
I meant the toxicity of what the child's been exposed to prior to taking the tissue out of the child.
Yeah.
So maybe I'm missing something.
Yeah.
So you feel that you're able to have a pretty good idea if you're dealing about the impact of toxicity on these tissue.
Yeah, so the point was the data that I talked to you was data from cancer survivors. That means that they had been exposed to therapy,
Yes.
and yet those cells that were in their body when they were exposed were the cells that produced eggs or sperm that allowed them to have a child, and it was safe. So even though we're not thinking about fertility preservation in that context, it tells you that if you have cells in your body that can produce eggs or sperm and it had exposure to chemotherapy or radiation, those cells can develop up normally. Now, when you do the fertility treatment in the laboratory, if the eggs aren't good, then the embryos won't develop. You'll never get to the point where they can be transplanted. So I think that nature takes care of a lot of it. If there's damage to the eggs such that the embryo can't develop normally, then you'll never transfer it. And or even if it does, it may not establish a pregnancy again. That could be due to genetic defects that were caused by the treatment. But we don't have any evidence.
Yeah, that's what I'm concerned about. Yeah.
Yeah, so we don't have any evidence for that, but by and large, if it's not a really good quality egg, it isn't going to lead to a pregnancy.
Thank you very much, doctor, for your work.
Sure.
Hi, thank you. In regards to pre-pubertal males who have already completed treatment, whether they do the high-dose stem cell transplant or not, they've obviously went through other high-dose chemotherapies. For those children who have completed treatment, what type of follow-up do you recommend in regards to tracking to see if they are producing what they may need to have?
Sperm, you mean? Yeah, we worldwide are bad at this, but it's a worldwide conversation that we should be monitoring the fertility of patients when they're in survivorship, basically. And for boys, this is relatively simple. You just collect a semen sample and see if there's sperm in there. And if there are, it won't just be coming back temporarily. If there is sperm there, there's going to continue to be sperm there forever. Why? Because it's a stem cell-based system. So if stem cells survived and they produce sperm, they'll continue to produce sperm throughout life. On the female side, it's a little, so first of all, the assessments are different. We typically would do two things. One is we measure a hormone called AMH, which is produced by the growing follicles or the mature eggs. And the other thing we do is a pelvic ultrasound, which is just taking a picture of the ovary and showing that there are large follicles in there that are producing eggs. However, we think about that different because any person with ovaries who gets a treatment that's gonadotoxic, women are born with all the eggs they're ever going to have. And that number of eggs usually gets them to about 40 years of age where there's a reasonable chance that they can be fertile and have a child. Once you get beyond that, fertility, really beyond 35, fertility starts to go down. So if you get a chemotherapy, even if it doesn't make you infertile right away, if you take your pool of eggs that was this big and shrink it down to this big, well, now menopause is going to happen earlier in life. It may happen at 28 years of age. It may happen at 25 years of age. And so, first of all, we should do the follow-up assessments of fertility. But for people with ovaries, even if you have follicles and even if you have a good AMH level, there should be a discussion about family building if they plan to build a family. And they would have the option, for example, to freeze eggs that would be available for them in the future if it should happen that they become infertile by the time they're ready to start their family.
So would the follow-ups occur then for the males at the age of typical puberty, or would you recommend the follow-ups to begin relatively shortly after treatment regardless of age?
So first of all, I tell you worldwide, we just really don't have this. We don't have it in our place. One of the best places for it is Aflac Children's Hospital in Atlanta, where they have the talk. And the talk, it happens at age 18. And I think they follow their patients for through 24 years of age. Every children's hospital a little bit different. But they have the talk at the age of 18, because now the child is mature. They don't need their parents there, and they can be treating directly the child for their fertility. And they'll follow up those children for at least one follow-up after the original assessment. So if you have somebody who is somebody with ovaries who had whatever levels of AMH, but you see those levels are going down by your follow-up treatment, it's a good indication that they're getting closer to menopause.
Okay, thank you.
Mm-hmm.
How you doing? Thank you for the presentation. Our daughter unfortunately wasn't able to go through the preservation process just due to the nature of how quickly we got into treatment, dealing with, side effects and all that stuff.
Yeah.
So for someone in her position where we're really unsure about what the future holds for her, what kind of, similar to that question, evaluation process, but also you talked a lot about autologous
yeah.
Tissue.
Yeah.
Are there options for donor tissue, or does it have to come from?
So that's an interesting and progressive question. So you're asking if she could have somebody else's tissue transplanted back into her, like maybe mom or sister or something like that. Yeah. So this is I would say that this is a cutting edge and controversial topic. And the thing that I'll say that's just obvious that anybody would understand is, of course, if she gets a tissue from somebody else, there'll be the chance of immune rejection, so she'll have to be on immune suppressants in order to receive the organ. But I will tell you, I just talked to a woman last week who said, who was infertile, but she had a sister who was willing to donate to her, and I referred her to my friend in St. Louis, Sherman Silber, who actually has done sister-to-sister transplants on a number of occasions now. The immune suppression regimen is not terribly challenging, and he hasn't published it yet, so I can't remember if and how many live birth outcomes he has, but he immediately responded and says, yes, we have a protocol, and send her down, and so they'll be going there.
Great. And as far as the evaluation process for someone in my daughter's position, does that look different than what you're speaking to on the male side? Understanding outcomes for where she is, if that's not.
So a fertility assessment, and by the way, even though we as a treating community haven't put mechanisms in place to make surveillance a thing, you can motivate that, as patient and family, and say, hey, we'd like to have fertility assessment, and this could happen, I would say, anytime in, let's say, the late teenage years or whatever. Obviously want to be sexually mature. The pelvic ultrasound involves sticking an ultrasound probe up into the vagina, and so that'll be part of the discussion to make sure your daughter's comfortable with that. But yeah, you can motivate that yourself. These are routine assessments that happen all the time. And again, if you do an assessment and get whatever the result is, but you see that the result is declining over time, well, then you know that the end of the fertile window might be approaching faster than it normally would.
Gotcha. Thank you.
Mm-hmm.
Is that it?
Thanks, everyone.
Thank you. Thank you, Dr. Orwig.